All right, everyone, we're going to go ahead and get started on the EMT lecture series. This is our chapter one, EMS systems. Certainly not the most riveting chapter, no blood, guts, or glory in this one, but it's okay. It's still tested, and I think it's important, to know the foundations and the history of EMS and how much progress has been made in really just a few decades. So we'll go ahead and get started. We are using the advanced EMT textbook, but don't panic, okay? If you're in an EMT class, that's fine. Not that much more information. You'll see this throughout the lecture series. The advanced EMT book has just a little bit more information. That's why we use it for these templates. One of the values I'm going to try to bring to this lecture is how these things are tested. I've went in and looked at the Q bank and seen how these will be tested. So I'll tell you on a few of these points. They'll test they test this type of material in this way, and I'll tell you. Um, so basically, this chapter kind of goes over like the core and the beginning of EMS. Um, and I'm going to skip these first ones because we're going to go into greater detail here coming up. But um, let's go ahead and start here. This is really where I want to start. This won't take very long. So the licensure requirements kind of vary state to state. So states have the power to decide how they license people, whether that's a plumber or a doctor or a EMT. States get to decide that. So it varies. Okay. Now in Texas, I'll give you an example because we're in Texas, right? Um, you when you earn your National Registry of Emergency Medical Technicians, you earn your certificate as an EMT. Then, if you want to work or volunteer in the state of Texas, working in healthcare, you have to become licensed by the state. And in the state of Texas, you do actually have to have a high school diploma to work, not to complete the course, right? Not to be nationally registered, but to work or volunteer as an EMT in the state of Texas, you have to finish your high school diploma or GED or equivalent. Okay. In Texas, you don't have to have proof of vaccine, but some states you might. In Texas, you actually don't even have to have a valid driver's license, which you do have to have a form of ID. Now, there's just different variants in this, so I wouldn't spend too much time on this. Remember, this is a national exam that you'll be taking, so they're not going to ask you about state-specific stuff. Um, but you're going to have to probably pass a background check just so you know. I know paramedics who have lost their license for getting several DUIs. Just be careful with that. If you get arrested or have a criminal background, like a marijuana possession charge or something like that, you could have a really hard time gaining licensure or maintaining your licensure in that state. So be careful getting silly charges added onto you because you're going to find working in healthcare very difficult if you do. Some employers will drug screen you. You might have to be BLS CPR certified, but at a minimum, I would say these bottom ones are very universal, right? So you have to finish a state recognized EMT course. You have to pass the state recognized written certification exam. In this case, Texas uses the National Registry of Emergency Medical Technicians. It's a national exam that most states and territories use. And then we end up doing, Texas has a set of skills that they'll have people do. And you'll do that throughout the course, so don't panic on that. But basically, you have to demonstrate that you're psychologically and physically ready to do the job. And you have to comply with not just the state, but you have to comply with the county and the city and the employer and all these different provisions and rules that are set. So, for like example, in Dallas County, you have to be certified by or it's the city of Dallas actually. You have to get like an ambulance employee permit. So you have to be licensed by the city even. So anyways, it varies state to state, and you don't really need to know what states do what, but I'm just giving an example. So you like, and I already just said this. So you'll have to pass the state recognized exam. Usually that's the NRMT exam. Some states still offer their own exam, but Texas, for example, we don't have our own exam. What we did was we said this exam is really hard to administer and to mess with, so let's just use someone else's exam. So that's how this came about. We end up using the National Registry's exam. Okay. Now, I just really quickly want to talk about this because the book, for whatever reason, goes in pretty great detail with the American with Disabilities Act. So basically, ADA protects people that have disabilities from being denied access to stuff, right? Whether that's programs or services or buildings or whatever, they just deny it. It protects people with disabilities from being denied access to stuff when reasonable accommodations can be made. Okay. Um, and so basically, I give an example, and this is a spicy subject, but if someone is completely blind, right, has no vision, they probably could not work as an EMT, right? That's not a reasonable accommodation for someone who cannot see anything to be able to assess a patient or drive an ambulance or something like that. So that's more like a what's called a bona fide requirement to do the job. But maybe someone that has dyslexia or someone that walks with a limp or someone that needs to use a cane, you could make reasonable accommodations for people in those instances. And that's basically what happens is the ADA says people with disabilities, you need to try to provide reasonable accommodations to them. Okay. Um, Now, the history of EMS, really interesting. So first off, let me start that EMS in its modern phase was probably developed in the 70s and 80s. So we're talking about only like 4 or 5 decades of true like ambulance, like put people in an ambulance and go get them, right? But you're going to learn that a lot of trauma care and a lot of things we know about trauma and healthcare today came from the battlefield, right? So EMS really started in the Civil War, 1861 to 1865, if I remember right. Um, so several centuries ago. And then it progressed, right? So Civil War was obviously a major war, and then it progressed to World War I and then World War II. And basically, we started realizing when we have casualties on the battlefield, we need to get them off the battlefield and try to treat them. Well, that the logistics of transporting an injured soldier is quite difficult, especially when it hasn't been done before. And as medicine was progressing, we realized, oh, there's treatments for these soldiers that are wounded or injured, and if we just leave them on the field, we can't treat them. So this is kind of where the beginning of picking up people and moving them and treating them in the process occurred. So it started in the Civil War, and it's with each war and major conflict that we've been involved in, it's grown. Okay, so by the Korean and Vietnam conflicts, we were doing this pretty well, right? There was medevac helicopters and field hospitals, like I'm sure you've seen the show MASH, right? Where it's field surgeons, where they're coming in and they're starting to treat patients for burns and shrapnel injuries and gunshot wounds in the field, and then stabilizing them and moving them towards more definitive care. So this continues to progress, and even now in the Middle, when we were in the Middle East and Operation Iraqi Freedom or in the war against terrorism in the early thousands, we were using this, of course, right? So battlefield care is probably the original foundation of EMS. Okay, now what's really, really annoying is they ask you this a lot on exams, okay? So I'm just quickly going to zoom in on this. This is straight out of the book, out of a book. And basically, this is discussing what each of these documents mean and what the document did to the EMS system, like where it contributed to us as a profession. So modern EMS was originated in 1966, and I'm telling you, you actually have to know this by this publication. It was a white paper, right? This was called Accidental Death and Disability, the Neglected Disease of Modern Society. And basically in 1966, that was published. And then in like 1973, the Emergency Medical Services Act came out, and it talked about, okay, what does a federal government as a whole want from an EMS system as far as like, EMS research and like, prevention and transportation and, evaluating the effectiveness of this and mutual aid agreements and all these things come out in this like big bill in this 1973, so the early 70s, that said, this is what we think EMS should be. It was kind of like the foundation. But what started this all, the match that lit the barrel on fire was the paper called The Accidental Death and Disability, the Neglected Disease of Modern Society. That was the one that really kicked it off, okay? And the Department of Transportation, a federal bureaucracy, published the first national standard curriculum as a guideline for EMTs in the early 70s. That's what I just said, right? So a curriculum that basically said, okay, we want EMTs to know how to take up blood pressure and to know what anaphylaxis is and to know how to do airway adjuncts. And that is a standardized curriculum. And we still follow that curriculum today with variations, right? It's a living document. It's changed. But that document is still happening today, okay? So that's kind of some brief history that's occasionally tested, right? So AAOS, which is the American, the Academy of American Osteopathic Surgeons. I'm making that up. Should have read that. Let me 1 second. It's the American Academy of Orthopedic Surgeons. Published their first textbook in 1971. So again, this is really starting to take off in the late 60s, early 70s. And then the EMS system really started to develop, right? So in the late 70s, the Department of Transportation developed this standardized scope with this is how we want paramedics and EMTs to be trained. And in the 1980s, the EMS national standard curriculum were developed. Okay, so this has been a process. If you don't know, probably in the 70s, funeral homes were in the business of ambulances, right? So funeral homes had a vehicle with a cot in it, and they would go out and pick people up and take them to the hospital. But talk about a conflict of interest. If they didn't take you to the hospital and you're dead, they're getting paid either way. So that was the beginning of EMS, was hearses, right? Like a hearse. And then it's progressed. Okay. So there's some old timers that used to work for the funeral home. Like I've met people in my career. They're like, oh, I used to work for the so and so Ray's funeral home in Fort Worth, and they would go pick up patients. So what I'm trying to illustrate here is there's been this really big shift of EMS in really not that big of a time, in my opinion. 50 years really isn't that much time considering how big the profession is now. Okay, so basically the availability for ALS care grew, right? So as time went on, emergency medicine has this kind of bad thing that we do where we say, oh, we'll do that, we'll do that, we'll do that, we'll do that. And they just raise their hand anytime there's a problem and saying, yeah, we'll do that. Well, that's kind of how the profession has grown, and because we are always willing to say we will do that because we know it's going to benefit our patients. And that's kind of to a point how we've progressed so fast, but in some ways our demise because our scope has gotten so big and so expansive because we never say no. We just say, yeah, we'll do that. Whether you're an emergency medicine physician or just, or an EMT or a paramedic, we just keep saying, yeah, we'll do that. And that's kind of a good thing and a bad thing, in my opinion. But in 1990, you need to know what this word is. This is the National Highway Transportation Safety Advisory, NHTSA. So I'm going to just keep calling it NHTSA moving forward. And basically, it's a federal bureaucracy, right? It's like a piece of the federal government, bureaucrats that basically say they laid out this agenda in the 90s, right? They said this is where we think EMS should go. So if we're going to spend federal dollars, this is how we think we should spend it to get to this goal, right? It's an agenda. And then in 2019, they came out with another document called NHTSA, right? NHTSA published the EMS Agenda of 2050. They said, okay, by 2050 and at these steps, we want to be here on education, here on research, here on this, here on that. And your book goes into greater detail talking about that. But that's kind of just some general stuff. It's probably worth knowing. So there's different levels of training. And again, this varies state to state, but I'll try to explain this, right? So licensing you to work is a state function, okay? Not certifying, but licensing you to work is at the state level, okay? So states get to say, Hunter can be a paramedic in the streets, okay? He's met X amount of criteria, and we're going to bless him and quite literally hand him a piece of paper that says he is allowed to practice in the state of Texas, okay? And then at the federal level, they really do like the practice model and like the national EMS scope, right? So like they decide as a whole, this is what we think that EMTs and paramedics should do. And then at the state level, that can vary a little bit. So they regulate EMS provider operations. So like the Parker County Hospital District EMS, they're told by the state, you have to have a designated infectious control officer, and we need your guys to all be licensed, and we need to have proof of insurance on your vehicles, and we need to know how many vehicles you own, and we need to know your station locations and who your medical director is. So regulation really happens at the state level, okay? And then at the local level, right? So at the Parker County Hospital District, for example, day-to-day limits of what the paramedics and EMTs can and can't do, that happens with the medical director. And the medical director, notice the MD, this is a doctor, okay? So this is a doctor. So they're usually board certified in emergency medicine, and they get to tell people what to do at the medical level, right? So yes, we want you to start IVs in these scenarios. No, we don't want you to give epinephrine in these scenarios. And that's decided by the medical director, okay? This is a really cool initiative that basically, we've realized that if we train bystanders to start care sooner while the ambulance is responding, people have better outcomes. Okay, that's not surprising. But basically, if we can have bystander CPR or a bystander do the Heimlich maneuver or a bystander apply a tourniquet, then patients have a lot better outcomes. Okay, a project I've been involved in is we've trained Stop the Bleed, and you'll do a Stop the Bleed class in this course, and you all become instructors. To like probably, I've trained personally probably around 5,000 people in Stop the Bleed. And schools and teachers, probably your exact teachers I've trained in Stop the Bleed. they have to be trained every year in Texas. So that's just an example of like a public outreach, public health initiative. Okay. Now, AEDs, excuse me, these are automatic external defibrillators. So pretty obvious, right? So it's automated, as in you don't have to do much. Externally defibrillate. So this is like where they rub the pads together and say clear, and they shock someone who's in a cardiac dysrhythmia, right? These are very effective. These save a lot of lives. So you'll hear me say over and over again in this lecture series, what saves lives is early access to high quality chest compressions and early access to defibrillation. That's what saves lives, okay? So those are AEDs. You've probably seen these in your schools or in public, okay? And they tell you what to do, like stand clear, apply pads to bare chest, call 911, right? It tells there's a voice in there that's telling you exactly what to do, okay? So let's talk about the different levels of first responders. This is tested, okay? They'll ask you if person X can do IVs and intubation and cardiac management, what type of level of training is required to do that? So that's how that's tested, okay? So this does get tested. But we're starting at the very bottom and working our way up, okay? So at the lowest level, still a valuable level, but at the lowest level, there's something called EMRs, or the Emergency Medical Responder. So this is the lowest level of training, and it's very similar to EMT level training, but they don't do clinicals. So in your course, this specific course, you're going to do 60 hours of clinicals, but an EMR doesn't do those. So these are people that have medical training, like law enforcement, firefighters, certain firefighters, park rangers, ski patrol, right? Okay. And their goal is to just initiate medical care, okay? They're going to provide BLS care with very limited equipment, and that's kind of what they do. So EMR is the lowest level, okay? Now moving forward, what we're in, right, emergency medical technicians, this is usually like at least a semester class, right? So 16-ish weeks of a course at a minimum usually. And so it's at least 150 hours of coursework. And this is kind of this is the next level up. Very similar to EMR, right? So we want to provide essential knowledge and skills to provide basic emergency care, okay? So this would be like, you know, packaging and transport and stopping the bleed and airway, like using a back valve mask, applying a non-rebreather mask, applying a nasal cannula. You're going to learn what all those are through this course. But this is the next level up from EMR. It is what's called an emergency medical technician, or an EMT, okay? Now, the very next level is an advanced EMT, right? And so these are even more training. And their big thing that they do is this, right? They're trained to start IVs. And in the state of Texas, actually, they can intubate. So this is where intubate. This is where you can put a tube down someone's trachea, their windpipe, and breathe for them, okay, and seal off their trachea so they don't choke. So this is a little bit more training, and they can do quite a bit more. So the advanced EMT does all of the BLS stuff plus a little bit of ALS, like IVs, a few life-saving medicines like dextrose, epinephrine, Narcan, a few others. But anyways, that's kind of the next level. And then paramedic, this is beyond, this is by far the highest level. So you can see a major jump of 800 to 1100 hours beyond being an EMT, right? So the EMT was 150 hours plus 800 to 1100 additional hours. A lot of training, okay? This is 1 to 2 years of training. So, for example, the Park County Hospital District offers a program that does this, and basically you have to be an EMT to enroll, and we'll give you you're in the program for about a year. And it is a tremendous amount of work. Hundreds of hours of clinical write-outs, lots and lots of hours outside of the classroom spent studying. But they do a lot, right? They do surgical airways, and they can pace your heart and slow down your heart and speed up your heart and stop your heart and change your blood pressure and give you pain medicine like morphine and fentanyl and ketamine, and they can stop your seizure and all these drugs and medications that are really important to treating patients is at the paramedic level. Okay, so they do what's called ALS, which is advanced life support. Okay. Now, so do you know those levels? Okay, it's tested in the book. There's a discussion, like a chart with what all they can do. I'm not going to read that to you. Now, I talked about this whole EMS agenda thing. This is to create a more cohesive and consistent system across the United States. So this is what we're seeing is EMS is kind of fragmented and really developed in certain parts of the country and not as developed in other parts of the country. It's usually related to funding and population. Um, but the idea is that's one of the goals is to make a more consistent system across the United States. Okay. So there's five key aspects of people-centered EMS system according to the EMS Agenda of 2050, right? So I'm going to read this to you. Comprehensive, quality, and convenient care, evidence-based clinical care. This means evidence-based clinical care. It means based on research, okay? So we're going to start using research and scholarly sources to base our care off of, okay? Efficient, well-rounded care, preventative care. This is really big. This is new. And comprehensive and easily accessible patient records. Now, this preventative care, we're going to talk about like mobile integrated healthcare, but that's becoming really big because EMS has always been a reactive force, not a proactive force, but now we're moving into this reactive force. Proactive force, where we're really trying to get ahead of the emergency before it happens and keep patients out of the hospital. Um, so, anyways, more of the visions, right, for a people-centered EMS system according to the EMS Agenda of 2050 is safe and efficient transport, care that reduces physical, emotional, and psychological suffering, and focus on preventing injuries and illness, and access to a patient comprehensive medical record. Okay, this is the repeating themselves, so I'm not going to keep reading that to you, but you get the idea. So, this whole public access thing. So, we want the public to be able to access the 911 system and EMS ambulances easily. So, one of the ways we do that is through our 911 system, where trained dispatchers will get this information from the patient. I used to be a dispatcher while I was working full time as a paramedic, kind of did on the side. And basically try to provide care before they arrive. So there's these things like what's called, I think it's on this slide right here. Yeah, emergency medical dispatch. So emergency medical dispatch. So this is it's like a week-long course at least. It's really hard. Course that will train you to when someone calls, you can talk them through how to deliver a baby or how to do CPR, how to stop the bleeding, and gather the information and use like an algorithm of questions to get the right information to the paramedics that are responding to the call. So just be aware. One thing I'll tell you from experience is reality of the call may differ from the dispatch description. So I've been dispatched to a priority 3 fall, which is where we go to the address with no lights and sirens, non-emergently. And you get there and the patient's dead. They're in cardiac arrest. So the dispatcher is only as good as the information that's given to them. So a lot of times it's not even their fault. The caller's non-compliant or just stupid or whatever. They're not doing it right. So basically, don't blame the dispatchers always. A lot of times they did their job, but the caller did not do theirs because people do weird stuff under stress. They don't really think clearly when they're freaking out and calling 911. So it's not always the dispatcher's fault. So don't hate on dispatchers. So yeah, I'll give you an example. So like new technology helps responders locate their patients. There's this thing called triangulation where if I'm calling here and these are all cell phone towers, they can use GPS to figure out exactly where you're at within about 10 meters of where you're at. Pretty cool. So that's called anti-alley. But anyways, there's triangulation that does actually occur. It's not just the movies. And like the Park County Hospital District uses that technology. So anyways, the clinical care, of course, kind of why we're here. You're going to want to check your equipment daily, right? Make sure it's working. You're familiar with it. You know where it's all at. I'll give you an example. One time, there's this lady got into a bad wreck. I was so new. I was probably like my first month of on the job, and she was on fire basically, and she's burning alive. Her legs are burning alive, and my paramedic partner's like, "Go get the fire extinguisher," because we're the first ones there. So I'm like running to the truck, and I didn't know where the fire extinguisher was because I was freaking out and I was stressed. Anyways, the lady was gonna die anyways, but I couldn't find it. I had tunnel vision, so if I was familiar with my equipment and knew exactly where it was, I wouldn't have had to search for it. I would have went straight to it. So make sure you know where your equipment's at. That's learn from my mistakes on that one. Oops. But anyways, just know that you got to know your equipment. You got to know where your vehicle. You got to know where all that stuff is. And I don't have much more to add on that. Now, human resources. Basically, what we're seeing in EMS, what was been really bad is you're either a paramedic, one of the few supervisors, or the director. Right, so there was like very little progression in the career. So like for example, probably 5 years ago at the hospital district, actually exactly 5 years ago, there was probably about 100 paramedics, 3 supervisors, and the director. So there was only 4 leadership roles at the agency. That's changed since then. There's probably close to 20 now. And so it was really hard to move up. So what we saw was people in the agent or within their career would spend their whole career working as a field level paramedic and never got the chance to move up to leadership because those opportunities were so rare. So one of the goals of the EMS Agenda of 2050 is to encourage systems to protect their people and create a career ladder where people can move up, okay, and do other stuff, whether that's community healthcare or education or supervisor or critical care or whatever. That's a good initiative, I think. Yeah, don't have anything to add on that. So let's talk about medical control. So the physician, so a doctor, a medical doctor, they're the ones that authorize the daily stuff, right? So apply oxygen in these scenarios, give epinephrine in these scenarios, intubate in these scenarios, whatever it is. So they develop something called protocols. So basically, there's a literal binder of probably hundreds of pages that sit on an ambulance that say, if you encounter a patient that can't breathe, I want you to do this. And that's called standing orders or your protocols. Now, that is all the time. So if I don't call a physician or I can't get a hold of them, I go to my standing orders and protocols and I do what the paper says. Now, if I have questions, I can try to call them and get what's called online medical control. And basically, this is where I can call them on the phone or on the radio and say, hey, here's what I'm seeing. What do you want me to do? And they're going to tell me what they want. So that's kind of an example. Those are two, different examples of using medical control. So yeah, these are doctors. So you need to know medical control, medical direction are medical doctors. They are doctors that do this, not paramedics, doctors. And I just explained this whole online and offline stuff. So remember, online, when you are in direct contact with them, so usually this is done by phone or radio, okay? It could also be done if they're right there in front of you, like face to face, but that's rare. And then offline, this is going to be your protocols, okay? Now, moving forward, basically these rules that are developed rules themselves are developed by a bunch of different people, but medical direction is developed by the medical director, okay? So that's kind of what this is saying. So the daily operations is usually done by like a chief executive officer, right? Like the EMS director who has delegates like EMS supervisors or deputy directors or whatever. And then medical stuff is decided by the medical director, okay? So that's kind of the shift. So you should think anything medical related, that's the medical director. That's his responsibility. Anything operation directed, like pay or vehicles or scheduling or something like that, that's decided at the supervisor or at the supervisor administrative level. Okay. So basically what we're trying to do, and this is getting a lot better as years go on, is develop a more integrated, right, like healthcare system to where we're working with our fire departments and we're working with our home health agencies and we're working with our mental health resources and crisis intervention teams and our hospitals and our nursing homes to work together to like coordinate care, because what we've had for a system for so long is it's very siloed and fragmented, right? We all have our own little responsibilities, but we weren't really working together. What we're finding, probably within the last decade really, is that if we work together, patients have better outcomes and we can work together to better serve our community. So, like for example, like our hospital in Weatherford, we meet with them monthly and we'll discuss stroke cases and heart attack cases and say, here's how quick it was from the time they called to the time the ambulance got there to the time the ambulance started transported. Here's the care the ambulance did. Here's what they did good. Here's what they did bad. Here's what we can do next time to be better. Here's the patient outcome. So basically we're working together to make better outcomes for our patients. So that's kind of this whole integration of health services. That would be an example. And this is happening a lot. And this just isn't the hospital district. This is all over. Okay. So mobile integrated healthcare, we have what's called a community paramedic program here at the hospital district. His name's John Martin. You'll meet him. Basically, he will come out to patients and his main goal is to keep patients well and keep them home. So if he finds out a patient has heart failure and they're at a high risk of being readmitted to the hospital, he may go out there daily or weekly and check on them. Hey, do you have all your medicines? check their blood pressure and assess them and talk to them. And a lot of times he does a lot of social work too. Like he'll make sure that patients have air conditioning or electricity or water or food or get their Meals on Wheels deliveries and have their prescriptions delivered and they're making their doctor's appointments. So all these things that keep patients well and keep them out of the hospital, and we're trying to prevent them coming or calling 911 in crisis. So that's a big thing that's happening with this whole mobile integrated healthcare, and I think it's really important that we're doing this. And we're keeping patients healthier longer, and we're also helping those that are disabled and unable to go get the healthcare they need. We're going to them. Okay. And something that John does is he does work with our behavioral health center here in Parker County. He works with the senior center. He works with Meals on Wheels. And that is his big job, is to keep patients out of the hospital. That is his goal. And not like slapping the wrist saying stay out of the hospital, but to keep them so well that they don't need to go to the hospital. That is a big part of his job. Okay. Now, the medical director maintains quality control. So he is the one that'll look at charts occasionally. He can delegate people to do this, but he could look at charts and say, oh, this call, I want y'all to do, you messed up and you should do this, this, or this, or on this particular call, y'all did really good on this. So he does quality control. Okay. So these are all synonymous terms, right? So CQI, continuous quality improvement, or what's called quality assurance. These are pretty much the same thing for our intents and purposes. They audit the aspects of the EMS call, right? And what we have to do sometimes if people make a mistake, which mistakes happen, we're all human, is we'll give them a little bit of extra training, or we'll say, you know what, we're really sucking at this. We're really sucking at, I don't know, auction administration. So we'll pull all our guys in our entire department and retrain them on how we want our guys to administer oxygen. So that's an example of like refresher training and continuing education. Okay. Now, there's a lot of times when errors can occur. I'm not really going to get into this, but basically, driving to the scene is really high risk, especially running lights and sirens. Communicating with each other and patient handoffs, big risk in that. A lot of it can go wrong. And patient can be dropped when lifting or moving them. That's probably where most people get in trouble, is lifting and moving patients. Whether they hurt themselves or hurt someone else, that's where people tend to get in trouble. So we want to eliminate errors as much as possible. Yeah, you don't say. Now, you got to ask yourself, why am I doing this? And really a better question is, would I want this done to me? Or to someone or would I want this done to my mother or brother or father or whatever, my friend? That's probably a better way to ask this is, why am I doing this and would I want this done to me? That's something I pretty much ask myself on every intervention that I provide pre-hospital. So they want you to know that using cheat sheets, their words, not mine, could limit errors, right? So these cheat sheets can help with like decision making aids and algorithms, right, with what should be done. Okay. And if you look at the airline industry, there's a reason that pilots use checklists and cheat sheets, because it is proven that it reduces errors. Okay, so humans make errors, but with cheat sheets and algorithms and checklists, we tend to make less errors. And of course, like I was discussing earlier, if we have a troublesome patient, we can discuss this with our partner or supervisor or our medical director. Okay, so we can just go talk to them like, hey, I had this bad call, or hey, I had this call and I think that this could have went better next time. What do you think? And just talk it out with your colleagues. Okay. Um, uh, I don't really want to talk about that, but I will talk about finance. So I think finance is interesting, but basically, EMS at the end of the day is a business, okay? Even for municipalities and cities and counties and states, right? It's still a business, okay? Because if the business doesn't make enough money to maintain their operation, then they fail at their mission, right? So the mission of the hospital district is to enrich the lives of our constituents to live a healthy life, right? It's not the exact phrase. But if we don't have the money to do that, then we fail at our mission. So we don't want to do that. So um, I'm going to talk about several ways that the EMS agencies are paid. But basically, you can know in the United States, we have paid EMS agencies like the Park County Hospital District. We have volunteer EMS agencies. I'm trying to think of one. There's not very many left. I really can't think of one anymore. There used to be one out at Possum Kingdom, but they're not. I don't think they're around anymore. Or a combination of both. This is probably a little more common, where you'll see a little bit of both. But how these departments are paid really varies. So it's not just one or none of these, right? So it's usually a combination, or all of these will go into funding the EMS department. So you can hire paramedics and have fuel for the trucks and buy medical supplies and have insurance and all those things. So the big way that we do this is through taxation. In the state of Texas, we use property tax. So every roof, whether it's a Walmart or a house, pays property tax to the county or the city that it's in. So that's a big way that EMS agencies are funded, is through taxation. Okay? Usually in the state of Texas, it's through property tax. Whether that's through an emergency service district or a city or a county or whatever, they're paid through usually property tax. Okay? So like the hospital district is a form of local government, so we tax houses based on their value. We tax it very like less than a cent, like it's actually 0.10 cents per dollar, based on their property values. That's one way this happens. The other way this happens is what's called a fee for service model. So when you call us for our services, when you call 911, we bill you, right? It's a fee for service, okay? Now, patient's ability to pay doesn't just dictate whether we take care of them or not. We take care of anyone that calls, right? But a fee for service model is basically, it's what it sounds like. If you call us for a service, we charge you a fee, we bill you, okay? So in our particular example, the hospital district, these are the two we use. If you call us, we charge you, okay? We take care of you whether you have the ability to pay or not. And we also tax property values, okay? That's an example. Now, someone like CareFlight uses what's called a paid subscription. So what they will do is they will charge like $100 a year. I'm just making up a number. I don't know what it costs. $100 a year for your household, and everyone in your household is covered because you're on our subscription plan. And basically, if you call an ambulance, you don't have to pay anything out of pocket. So that's a paid subscription. Now, donations is pretty obvious. People can donate money to you. Federal, state, local grants, that's obvious. So that's when other forms of government give out money. And then fundraisers like bake sales or car washes, or I went to one. Possum Kingdom used to have an awesome flea market. I don't know if they still do. They would raise a lot of money for them to operate throughout the year. Now, in pay attention, this is tested. In 2020, the Center for Medicare and Medicaid Services, right, CMS, implemented what's called the ET3, right? So emergency triage, treat, and transport, okay? And this is new. This is like really high-speed stuff. This is really important. And basically, what we've always done in EMS, up to 2020, the only way that EMS providers got paid for a fee-for-service model was to take patients to the emergency room. So someone with a sore throat, emergency room. Someone who's dead, emergency room. Someone who has an ingrown toe, emergency room, okay? And what this ET3 thing, the Emergency Triage, Treat, and Transport Act, does, this payment model by CMS, says, well, what if we use alternative transport? What if we take patients to urgent care centers or a doctor's office, or we just treat them on scene? We just say, oh, we'll treat your paper cut with a Band-Aid, and we'll charge you a little bit for that, and we'll go, right? That is the idea of ET3. So what has traditionally been is we only transport to the hospital, the emergency room. Now we can take patients, not everyone, this is a pilot program right now. Programs that are enrolled in this, we can get paid by CMS, by Medicare and Medicaid, which is the largest funder of healthcare in the United States by far. Probably like 2/3 of healthcare is paid by the federal government for the Center of Medicare and Medicaid. So basically, that's what's paying. So basically, now we can be paid to take patients to the urgent care of the doctor's office, or to treat them on scene, or to not transport them. We can still get paid by the federal government. So it's pretty cool stuff. And this is definitely the future of EMS. And there's been pretty good success in this so far. So this will be interesting to track. But I'm just letting you know, whoever tells you the National Registry is not an up-to-date exam, they're a filthy liar. The National Registry is a very up-to-date exam, so don't be shocked if you see something like this on your quizzes, on your national exam, or your in-class exam. You probably will. Okay? Now, education systems, I'm not going to talk about this much, but basically, they're licensed by the state, okay? But there's also national organizations that accredit them. I'll give you an example. In the state of Texas, the EMT program that you're sitting in right now is licensed by the state and accredited by this thing called COAMPS, right? The Committee of Advanced EMS Education Professions. I think that's what it is. EMS professional education, something like that. I can't remember what it stands for, but you don't need to know that. But what I'm telling you is the state is in charge of regulatory stuff, like, you know, what type of curriculum are you teaching? Who are your instructors? Who's responsible? Who's your infection control officer? Those things. But there's this national accreditation agency called COAMPS that also works. So it's, again, it's both, right? It's not just state, it's not just national, it's both. You don't need to. I don't really want you to know these exact details, but ALS instructors, they have to have a little bit more training. Sometimes these are taught at colleges or a career center or a hospital or whatever. Um, so that's kind of what I want you to know about that. Now, there's different ways that we can prevent public health injuries, right? So basically, public health and prevention is through primary prevention. So primary prevention would be like doing something before it ever happens. So primary prevention is like, I don't know, defensive driving would be an example of primary prevention, right? We want to train people how to drive really safe so they never even get into an accident. Secondary prevention is a little bit different. This is like the one that comes to mind. This isn't a good example for y'all. Is mammograms, right? So you're trying to catch something early on. Okay, so like you're trying to catch something before it gets big. But I don't think they'll ask you to differentiate between the two of those. Now, EMS research. This is really kind of the exciting part right now of the profession. Is EMS has really grown in the last few years to probably the last 10, maybe 15 years to really start leaning on research. And the field of EMS research has grown drastically every day. I went to a conference last week, and they were saying that just in related to emergency trauma care, there is about 72 new publications a day, every single day published on EMS trauma, not just medical, but trauma care. Or I'm sorry, emergency trauma care, not EMS, but emergency trauma care. So there's tons of research being dumped into our faces right now, and we got to figure out what's best. And so you're seeing changes where we used to use backboards on everyone, but now we don't use them as much. And I'm not going to confuse you on why we do or don't, but it's because the research is saying we should or shouldn't. And we're introducing new drugs and we're introducing new therapies and we're eliminating therapies and drugs based on what does the data say, what does the research say. I think EMS research is really important. I have some publications in EMS research, like papers that I've written or helped write. So this is important stuff, really exciting. Okay, so transport. We're almost done. Hang with me. Transport to specialty centers. Basically, I just want you to know there's burn centers, there's pediatric hospitals, there's trauma centers, there's stroke hospitals, there's heart hospitals. So there's different hospitals that do certain things. Some of them do it all, right? Some of them will do trauma, stroke, cardiac, pediatrics, you know what I'm saying? It just depends on the hospital. Just know there's specialty hospitals, okay? Now with that, you might have to, it may take longer to transport them if you go to a specialty hospital, okay? You'll hear this word thrown around occasionally. It's called an inter-facility transfer or an inter-facility transport. I really prefer the inter-facility transfer because you're going between one facility to another. So if I'm taking someone from the nursing home to the hospital, that is an inter-facility transport, right? So I'm going from one facility to another. Another example might be going from like one hospital to another hospital. That is an inter-facility transport. So that's what they mean by that. Now, I will quickly explain the difference between transfer and transport. In my opinion, and not just really my opinion, the literature says a transport is typically like a 911 call, right? You're picking someone up from a scene and taking them to a hospital. A transfer is usually like an inter-facility, okay? So you're picking someone up from a facility and taking them to you're transferring their care to another facility, okay? That's a transfer. Okay, so I know that sounds familiar and it sounds pedantic, but I want you to know the difference between the two. Okay, this is an annoying slide. Basically, be nice to hospital staff. Okay, they're your friends. We're all wearing the same jersey here. Okay, we're all on the same team. Don't be shitty to hospital people. They're good people. Okay, they have a different job than you. They're not better than you. They're not worse than you. Okay, we're all on the same team. We're wearing the same jersey. Okay, be nice to other public safety agencies. You don't have to be a jerk to people. Okay. Be nice to other fire departments, other police departments, other EMS agencies. Again, we're all on the same team here, okay? Now, I'm not going to read you these, but I want you to read these, and know these, okay? Make sure that you're a professional. I will say this on this slide. I'm going to hold here for just a second while you're reading these. Our profession, okay, and the trust that people have in us, in our profession, was not earned by you. It was not earned by me. It was earned by generations, decades before us, that have said, wow, when someone shows up in an ambulance wearing a nice clean uniform, they're not going to know my name, they're not going to know my education, but there's trust in our profession because of the people well before me that have built the public perception and trust in our profession. So make sure you have integrity and empathy, and you're motivated, and you're confident, and you're on time, and you're a good communicator, right? And you're an advocate for patients, and you do the right thing, and you have integrity, all those things, because you didn't earn that, but generations before us earned that for you, and it's a sacred thing that we get to hold and have. And healthcare is really unique because there's really not another profession I can think of where an 80-year-old lady is going to say, here's my purse, open it up. I want you to look in my wallet and find my medication list, and you can have it. Or here's my social security number. And they trust you're going to do the right thing with that. Or here's my dead child. They meet you at the curb with their dead child who's not breathing, their most prized possession. And they don't know who you are. And they hand it off to you and say, fix it. And they expect you to be able to fix it because of the generations before us that have earned that trust and privilege. So it's a sacred thing, and you really need to hold that close to your heart and realize the sacredity in that. Okay, this wasn't earned by you. This was earned by generations before us. Okay, and we have a duty to uphold that. Okay. Lastly, there's a picture in your book. It shows an EMT that looks like he got hit by a wrinkle bomb. Like he just looks terrible. You know, his stuff's untucked. His uniform's ugly. Don't be that guy. Don't be the guy showing up on calls with an untucked shirt. Don't be the guy that's smelly. Don't be the guy with an ugly haircut or bad hygiene or they're ugly, they're mean. You know, don't be that. You want to be this guy. You want to be professional with a clean uniform and looking fresh and looking crisp. It doesn't matter if you're volunteering. The patient doesn't care if it's 2 in the morning. The patient doesn't care if you haven't eaten. The patient doesn't care if you just woke up. What they expect is when they call 911 that someone who is trained, someone who is professional, and someone who is competent and respectful and has integrity will show up to their door and fix their problems. That is the expectation of the public of EMS. And those are really big shoes to fill. But we do it every time the tone's off, every time we're called, that's what we do. So I'll end on this slide. This wasn't the most exciting chapter, but I hope it gets you excited about EMS. This is a sacred profession. This is a really, really fun job. It's by far, I'm in medical school. I can tell you it's way more fun than medical school. It is a fun, fun job. So hold the sacredity of this job really closely and do your best every day because patients demand our best and they don't care what's wrong with you. When they call 911, they expect an ambulance to show up and do the right thing every time. So I appreciate your time and we'll end this lecture. Thank you.